So good afternoon. I'm thrilled to be here and really wanted to commend you for the multi-professional approach of this symposium and actually the multi-pronged approach to this symposium. And because I think that's utterly critical. So I'm Allison Whelan. I'm the Chief Medical Education Officer at the Association of American Medical Colleges. It's a member organization for all of the medical schools and academic health centers in the US and Canada. So I am not an accrediting body. We're not ACGME, we're not ACCME, we're not LCME. And so really bring you the perspective of really the member organization, sort of the medical schools. And I recently came from medical school where I was first a course director, then a curriculum director, then an overall education dean where we did a lot of interprofessional education. So bringing you that perspective. And I think it's important because too often when there's a problem, and there are multiple health problems. We recently were at a symposium where we were talking about opioid addiction. This problem that we're talking about here, different population, equally important, equally complex. And sometimes the answer is, oh, just make legislation to change the rule, to make accreditation in the MD program, and that will, fix the continuum. So I really wanted to stress is really the complexity of all the processes related to physician education. And I think we already know this, but just to be clear, accreditation is about the education program. Certification is about the practitioner. And they are both potential levers of change. And then credentialing, which I'm talking less about, is really the process where a specific scope and content of what an individual practitioner can do in the particular setting is. So I'm going to talk about primarily accreditation and certification. So this is the timeline of a physician training. After 4 years, typically, you complete medical school. You get an MD. You're actually not able to get an independent license at that point. After another year of internship, where you are in supervised practice, you can then get an independent license, which is state-based. Almost everyone goes on to residencies, pediatric residency, psychiatry residency, internal medicine residency. Then you can get certified. And then you can do a fellowship, which is subspecialty. So you could do pediatric psychiatry, you could do pediatric kidney disease, you could do pediatric cardiology. And then formal training is done. That's somewhere in the range of 8 to 12 years. And then the rest of the career is really much more independent. There is now, you have to maintain your license, which at this point is simply getting, not getting in trouble, and getting continuing medical education credits. Importantly, maintenance of certification is an area that is changing. We were asked to talk about areas that are changing. So maintain certification is an active area that's changing. It varies from specialty to specialty, but the idea is that you need to show continuous quality improvement, that you're doing learning in the scope of your practice, and that it is very intentional, as well as some basic exams as well. So this is a really important area of change. So where are in terms of testing for the individual, to get out of medical school and to get a license, you have to pass 4 written exams, the USMLE licensing exams. There are exams that are both written and potentially oral, depending on the specialty, for residency training and for fellowship training. And then for maintenance of certification, it's a variety of different things. It can be closed book exams, multiple choice, open book, and then typically it's also this continuing education that's more directed in a big area of ongoing change. So those are really thinking about the individual. For accreditation, which is program accreditation, for medical schools, it's Liaison Committee for Medical Education. For residencies and fellowships, it's ACGME. And then CME, so continuing medical education, is for the continuing medical education. So those are the accrediting bodies. And what's changed in those? I think one really important aspect when we think about all of our training, all of our credentialing, and where we're trying to go in terms of the certification also, is we've really moved to competency-based credentialing. and we're moving towards. It's an active process. I think that we're really trying to figure out some of those areas. These tend to be the areas in which there's general agreement that these are the large areas of competency. And this is true from medical student through the practitioner. And as you think about competency-based credentialing, the idea is that there's a continuum. As you start out, you don't know anything, and you become an expert. And that level of competency is really what you need for the independent practitioner. And then we think about the expert being the consultant, the teacher, the leader. And then the other thing that's important is we think about competency. So if you just think about communication with families, that depending on how much of a specialist you are, so medical students, general pediatricians, and pediatric psychiatrists all have a competency related to that, but it becomes much more specific and detailed as you become more of a specialist. So there's very refined competencies when you are this level expert in a competency area. So the question that I think we really need to think about, whether we're talking about child behavioral health or opioids or any of the other complex problems we face, is where is the real problem with the competencies? Is it a general, widely applicable, largest target group, in which case it should be at the medical school level, it should be incorporated into USMLE exams, it should be part of the accreditation at LCME. If it's more specialized, then you can focus on the certification at the pediatric level or even the subpediatric level. And if it is, depending on scope of practice, the area that I think has been most neglected in the medical education world of physicians is actually continuing medical education and really developing that as our understanding of things change. So I already talked about this, that if it's broad-based, so what has happened? Where have we done things with that? Cultural competency or unconscious bias or interprofessional education, big, huge gaps. They've been added to LCME accreditation. They've been added to our STEP exams, and it's at that level. When you think about it at the more pediatric level, this is the question you should be asking yourself. Is it something all pediatricians aren't recognizing things, don't know when to refer, don't know how to do basics? Or is it the more advanced groups? Because I think we can't do everything. So identifying what the biggest problems are and where to identify that, I think, is critical. And again, I would come back to this, that we spend most of our life as physicians practicing. We change our practice over time depending on where we are, who our patients are, and the ability to create opportunities for practicing physicians to learn what it is that you think that they need to learn is huge. They have huge independence. Basically, we have to choose our continuing medical education as long as it meets criteria of being patient-based, connected to looking at outcomes, and connected to our scope of practice. There's a panoply of things out there, but people will look for high-quality continuing medical education opportunities that fit that if they see that there's a big gap. So I would suggest this is potentially a really big area to concentrate on developing more materials. So the real question to me is, if you think about levers for change, and I do think that accreditation and credentialing can be, but it needs to be at the right level. So we challenge this group to think, what are the critical competency gaps at each level of physician training? And if there's something big, then focus there. If it's more scattered, then think about that. And I would strongly recommend, and I say this to almost every group, having been a curriculum dean and now sort of looking at it more broadly, that one of the greatest opportunities is to create great learning and teaching opportunities for the physicians in practice, and even at the credentialing level for in fellowship and residency training. Because if you make great teaching tools available, people will use them. And if you just shake your finger at them and say, do it, but you don't give them the tools, then people just get frustrated and they feel bad and they can't change their behaviors. And I will stop there, and we take questions at the end, right? And I have 32 seconds to spare.